Let's go ahead and get started. So in today's video, we're going to be talking about macrophages. Additionally, how macrophages are involved in acute inflammation. By the time this video ends, you will completely understand the role of macrophages in acute inflammation. Also, a brief overview of what macrophages are, phagocytosis and mechanisms of killing, how macrophages dictate inflammation from acute to chronic, resolution, key cytokines that are involved, abscess formation, transition to chronic inflammation, and at the end we'll throw in a few USMLE practice questions to not only solidify your knowledge but also test it. Be sure to check out thehealingpowerofnature.com and also our Patreon for the best materials available on the market. So to begin, let's talk a little bit about macrophages and acute inflammation. I want you to imagine a castle, the castle representing your body, which is under attack by invading bacteria or pathogens. The first responders are the neutrophil army, okay? So the castle sounds the alarm, inflammation begins, and neutrophils arrive immediately. The brave warriors, which are neutrophils, charge in, attacking bacteria with reactive oxygen species, or ROS, and also enzymes. However, neutrophils are short-lived and begin dying off within 24 to 48 hours, which also form pus, which is their remains. Next, the generals arrive, the macrophages take over. Macrophages arrive 2 to 3 days later, surveying the battlefield. They ingest the remaining debris and decide the next step. If the enemy is defeated, they release IL-10 and TGF-β, which are anti-inflammatory cytokines, to start healing. If more reinforcements are needed, they release IL-8 to call more neutrophils. If the enemy is persistent, they activate the immune system using CD4 plus T cells via MHC class II molecules for chronic warfare. So transition from neutrophils to macrophages. Macrophages typically predominate in inflammation after neutrophils, usually around 2 to 3 days after the initial injury or infection. So neutrophils are the first responders and work quickly to phagocytose pathogens. However, after their initial response, macrophages take over to clear debris and help transition the inflammation from acute to a more chronic or healing phase. Macrophages are derived from monocytes, which are a type of white blood cells circulating in the blood. When monocytes migrate into tissue, they differentiate into macrophages, where they are tissue residents and have a longer lifespan. So remember, monocytes are in the blood, macrophages are in the tissue. That's an easy way to remember it. So macrophages function in acute inflammation, phagocytosis of pathogen and debris. Macrophages help clear dead neutrophils, tissue debris, and microbes through phagocytosis. An example is after a bacterial infection, neutrophils kill the bacteria but die in the process. Macrophages come in to clean up their debris, ensuring that the site of infection is cleared and ready for repair. Macrophages release a variety of cytokines like tumor necrosis factor alpha, interleukin-1, and interleukin-6 that continue the inflammatory response, recruit additional immune cells, and help with tissue repair. TNF-alpha and IL-1 also induce systemic effects such as fever, leukocytosis, and acute phase reactants. So the promotion of tissue repair, as inflammation progresses and begins to resolve, macrophages switch their role from a defender to a repairer. They promote tissue healing through the secretion of growth factors, collagen deposition, and the resolution of inflammation. Macrophages can be polarized into two main types based on the signals they receive. The first is an M1 macrophages. These are pro-inflammatory macrophages which produce inflammatory cytokines and help combat pathogens. An example is in the early stages of acute inflammation, M1 macrophages are involved in the pathogen clearance. Next is M2 macrophages. These are anti-inflammatory macrophages involved in tissue repair, resolution of inflammation, etc. An example is after the initial inflammation has been controlled, M2 macrophages help with the wound healing process and transition inflammation to resolution. So how macrophages arrive at the site of inflammation? Macrophages follow the classical leukocyte extravasation steps. If you need more help with these specific tests, I would go back to our acute inflammation neutrophil video where we go into these steps in depth. But just a quick review. First is margination, so cells move towards the vessel wall due to the slowing of the blood flow. Next is rolling, where selectins like P-selectin and E-selectin help slow down macrophages. These are the speed bumps. Next is adhesion, so integrins, LFA1 or MAC1, for examples, allow firm binding to endothelial ICAM1. Next is transmigration or diathesis. PCAM1 facilitates passage between endothelial cells into the tissue. So enhanced phagocytosis by opsonins. So opsonins are molecules that enhance the recognition and ingestion of pathogens by macrophages. There are two major opsonins involved. The first is IgG, or immunoglobulin G, which can bind to the surface of microbes. This marks them for destruction by macrophages. Next is C3b, a component of the complement system. C3b, like B for bind, binds to the pathogens and acts as an opsonin, enhancing the macrophage's ability to identify and ingest the pathogen. So remember, opsonins are the tags for macrophage recognition. Think of IgG and C3b as tags that make it easier for macrophages to spot the intruder. Next, how do macrophages kill the organisms? Once the pathogen is engulfed, macrophages utilize two main killing mechanisms to destroy it. The first is the oxygen-independent killing. This method relies on enzymes and other antimicrobial factors found in secondary granules of the macrophages. These enzymes include lysozymes, which break down bacterial cell walls, defensins, which are small peptides that insert into microbial membranes and disrupt their integrity, and lastly is lactoferrins, which binds iron, depriving microbes of their essential nutrients. These enzymes act independently of oxygen and help kill pathogens in the phagolysosome. An example is in a patient with a chronic granulomatous disease, CGD, defects in the oxygen-dependent killing pathway lead to recruitment of bacterial and fungal infections, but oxygen-independent mechanisms, like lysozyme, still function. The next is the oxygen-dependent killing, or the respiratory burst. This is a much stronger killing mechanism that requires oxygen and is referred to as the respiratory burst. When macrophages encounter pathogens, they activate enzymes that generate highly reactive oxygen species, or ROS, that kill the engulfed pathogens. The key components that are involved are superoxide anion, or O2-, which is formed by the enzyme NADPH oxidase. Hydrogen peroxide, H2O2, produced from the superoxide anion, and myeloperoxidase, MPO, which is an enzyme found in neutrophils and macrophages that further converts hydrogen peroxide into hypochlorous acid, HOCl, a potent antimicrobial agent. These reactive species are highly toxic and kill the pathogen by damaging cell membranes, proteins, and DNA. An example is in cystic fibrosis. Patients often have a defect in MPO production in neutrophils and macrophages. This leads to impaired bacterial killing and chronic lung infections. This demonstrates the importance of oxygen-dependent killing. So once macrophages have taken over the inflammatory process, they decide whether the inflammation will resolve, continue acutely, form abscesses, or become chronic. Here's how they manage it. First, resolution and healing. When the infection is cleared or controlled, macrophages shift their role to resolving the inflammation and initiating the healing process. They secrete anti-inflammatory cytokines that stop the immune response and promote tissue repair. So some key cytokines that you need to know: IL-10, this cytokine inhibits further immune responses, helping to resolve inflammation. It has strong anti-inflammatory properties. Next is TGF-β. This cytokine plays a key role in fibrosis and tissue repair. F for fibrosis. It helps stimulate collagen production and tissue healing. Next is continued acute inflammation. If the infection persists, macrophages will recruit more neutrophils to the continued site for more fighting of the pathogen and keep the inflammatory response active. IL-8, or IL-date as I like to call it, is the key cytokine that macrophages release to attract neutrophils. 8 as in date, they attract neutrophils. Macrophages and neutrophils go on a date. This helps increase the neutrophils to the site of infection. It is essentially directs the neutrophils to come to the rescue. An example, in an ongoing infection like wound infection, where the pathogen is not cleared, macrophages continue to release IL-8, or IL-date, which maintains a cycle of neutrophil recruitment and acute inflammation, leading to persistent pus formation. Next is abscess formation. The macrophages play a key role in creating the fibrotic capsule that surrounds the abscess, isolating the infection from the rest of the body. Pus is neutrophils and walled-off abscess. An example is in Staph aureus. This infection often leads to abscess formation. The bacteria trigger the immune response, leading to pus formation, and macrophages help wall off the infection by creating a fibrotic capsule around it. Next, macrophages can help produce chronic inflammation. If the infection or injury persists, macrophages shift to a chronic inflammatory response. They function as antigen-presenting cells, or APCs, and present antigens to CD4 plus positive T cells via MHC class II molecules. This activation of CD4 plus T helper cells leads to the release of pro-inflammatory cytokines, driving chronic inflammation. Some key features of chronic inflammation. So macrophages present antigens to CD4 plus T cells via MHC2 molecules. CD4 plus T cells release cytokines like interferon-gamma, which further activate macrophages and drive the chronic inflammatory response. This cycle of activation leads to tissue damage and fibrosis, often resulting in the formation of granulomas. An example you'll often see is with tuberculosis, TB. So Mycobacterium tuberculosis leads to the formation of granulomas. Macrophages act as antigen-presenting cells and present the bacterial antigen to CD4 plus T cells that release cytokines that perpetuate the chronic inflammatory response, ultimately leading to granuloma formation. Key cytokines to remember: IL-10 and TGF-β are anti-inflammatory. They're healing and resolution. IL-8 or IL-date is a date for neutrophil recruitment. Interferon-gamma activates macrophages in chronic inflammation. Some examples are pneumonia, alveolar macrophages clear debris, abscesses like in staph infection creates fibrotic, pus-filled abscesses, and in TB, tuberculosis granulomas. Macrophages encase bacteria but fail to clear them, leading to chronic disease. Let's go ahead and jump into a couple practice questions. Like I will always ask you to do, read your last sentence first, read your choices, and then read the entire question. These questions are very high yield. If you don't know the answer, this is classic USMLE type question. Start by eliminating the answers you don't know and then go from there. So I'll go ahead and give you a few minutes and then we'll come back. So if you chose C, interferon-gamma, that is correct. That's because this patient likely has tuberculosis, a disease characterized by caseating granulomas. So granuloma formation is driven by Th1 cells secreting interferon-gamma, which converts them to epithelioid histocytes and multinucleated giant cells. IL-4 and IL-5 promote B cell activation. IL-10 and TGF-β are anti-inflammatory cytokines. Let's go ahead to the next question. I'll go ahead and give you a few minutes and then we'll come back and review the question together. So if you chose B, IL-12 secretion by macrophages, that's correct. Remember, granuloma formation begins when macrophages engulf an antigen but cannot eliminate it. They present these antigens on MHC2 to CD4 plus positive T cells and secrete IL-12, which drives Th1 differentiation. Th1 cells then secrete interferon-gamma, further activating macrophages. IL-4 drives B cell activation. IL-10 suppresses inflammation. IL-8 is the date for neutrophils. And complement activation, more relevant in innate immunity and bacterial infections. So last question. I'll go ahead and give you a few minutes, then we'll come back and review. If you chose D, macrophage, that's correct. Remember, neutrophils are the first responders and predominate in acute inflammation. They're the first responders, usually lasting 24 to 48 hours. By day 3, macrophages replace neutrophils and take over as the dominant cell. Remember, neutrophils are the early responders. CD8 positive T cells and plasma cells are part of adaptive immunity seen in chronic inflammation, and eosinophils are important for parasite infection and allergies, not acute bacterial wounds. So remember, early inflammation is neutrophils, lasting 24 to 48 hours. Late acute inflammation, usually days 2 to 3, macrophages take over. Granulomas equals macrophages plus interferon-gamma. IL-12 is a key granuloma formation, Th1 activation, and neutrophil chemotaxis is IL-8 or IL-date. That concludes our video for today. Thank you for watching. Be sure to check out thehealingpowerofnature.com and also our Patreon for some of the best materials on the market. We appreciate your support and we'll see you next time.